Welcome everyone to Spine Time. A top spine surgeon in the state is now in our region, but this is refreshing. Dr. Marc Moisi says surgery is the last option he'll offer you. Today, we'll see how this innovative expert can finally ease your back pain. Dr. Moisi is the Director of Neurosurgery at the Hurley Spine Center in Fenton. He is fellowship trained as a complex and minimally invasive spine neurosurgeon who has written more than 45 peer-reviewed publications and multiple book chapters. He's also a research associate for the Seattle Science Foundation. Now, as soon as Dr. Moisi is done with his presentation, he is going to answer your questions live. Some of you have already submitted questions, but there's still time. Just text me, text, don't call, at 248-935-2562, or submit questions on Facebook or YouTube. Dr. Moisi?
Thank you. Thank you so much for having me. This is a very special occasion as I'm here at the Hurley Medical Center, really trying to push forward our regional neurosurgical and particularly spine care. So I'm going to go through some slides that I've developed just so we could have open up for discussion, and then of course, as we've mentioned, we'll decide and answer some of our questions. So when do we go to a neurosurgeon? That's a pretty important question, right? So let's go quickly through the spine. The spine and the spinal neural tissues is part of our central nervous system. It all starts with the brain, and then you've got your spine that goes under it and continues down and to our nerves, so we could do all our basic functions. Our spine has the cervical, thoracic, lumbar, and sacrum, and all have their respective nerves, as we could see here. Each one of these vertebrae, depending on where they are, they're a little bit differently structured, but the ultimate structure is the same, where you have two vertebrae, and they are connected with a disc. And sometimes we may have all heard of a herniated disc, and that's why they have these discs, which are our cushions, and so it supports our spine so the bone doesn't rub on bone. Unfortunately, some of these discs do herniate, or they go out of their normal area and may push on our structures. This is another representation of what our spine looks like, and not only does it have bone and disc material, but it's got the nerves in between. It's also got ligaments and tendons and all these other supportive structures as well that I'm not going to bore you with at this time. So the question is, how many Americans actually have back pain at one point or another? Over 80%, I would say, and I would actually venture to guess almost 100% of us have had back pain at one point or another in our lifetime, whether it's a strain because we lifted something heavy, or we picked something up the wrong way, or we may have slept the wrong way, or something more serious where it may end up with a disc herniation or something of more significance where I may need to see you. The most common causes do include nerve and from our muscles or muscular pain. Others are called degenerative disc disease, and the most common is arthritis. In terms of degenerative disc disease, and I have a lot of patients coming into my office saying, I have degenerative disc disease, could you help me? Well, degenerative disc disease, first and foremost, is not a disease. It's just the wrinkles and gray hairs of our spine as we go through life, doing it with our spine and its structures doing what it's supposed to do, protecting our nerves. Ultimately, there are multiple ways of going about treating all these ailments, and a lot of time it is, and most of the time, it's without a surgical intervention. So what we believe here at Hurley, especially at our spine center, is the multidisciplinary approach. In terms of the multidisciplinary approach, everyone's included. First and foremost is the patient and the patient family. This multidisciplinary approach is meant to be a patient-centric approach. The patient and the family are not just at the top of the list, but they're 1, 2, 3, 4, and 5. They are at the center of all our treatment plans. And of course, we have our internal medicine, our pain specialists, our radiologists, our chiropractors, case managers, and of course, at the bottom of the list is where I come in, which is our surgeons, whether it's your neurosurgeons or your complex spine specialists. One of the things that is the first that I tend to recommend to my patients. We've all heard of rehab. Well, let's change that term to prehab. What do I mean by prehab? Let's see if we could do all those exercises, get each patient better before you get to the rehab, meaning before you need a surgery to rehabilitate from that. Surgery is like a marathon, and what do you do to get to a marathon? You train. Well, in my thought is if you train to get to the marathon, you may just end up without needing the surgical intervention. You know, one of the consequences is you get better on your own. And one thing I like telling my patients is I can only get you better as good as your own body gets you. I can't get you better than that. So if you're already having put in the energy to get better and you do get better, the good news is you won't need me. And all I will be is a cheerleader on your sideline. And these are some of the possibilities within prehab, and we would recommend you to a physical therapist to help you along with these. We will also, if needed, discuss a referral to a pain specialist, and they have many different ways of treating these ailments that are non-surgical, and hopefully to avoid surgery to begin with. Now, this is a very sad slide because, as we all know, we're in the midst of an opioid epidemic. This slide is from 6 years ago, and the reason I haven't updated this slide is I'm frightened to see what the numbers are today. And my goal is to not get people hooked on more medication, but instead have them come off the medications and get their own bodies to heal them on their own in multiple different modalities. And that's why we're here. So what do we do as spine surgeons? Well, we do a lot. Our plates are very, very full. But it's two-tiered. The top tier, which is on the top line there, which includes our neck pain, our back pain, our disc herniations, deformity, and stenosis, those are the ones I would see in my office as a more elective practice, where we could really push through our envelope and see what we could do on a conservative basis. The second line is the more important one to understand, that sometimes we do need to be seen more urgently or even emergently in a emergency room, and we do see a lot of patients in our level 1 trauma center, whether it's a spinal cord injury, a trauma, or a tumor, and whether it's the tumor is from the actual spine itself or metastatic disease. Unfortunately, we take care of all those ailments here. So the most urgent consultations are, as I mentioned on the previous slide, are the ones where you may have a neurological deficit, and what I mean by that is you can't move your arms or legs in as good of a fashion as you typically do. You're tripping on your legs, you're dropping things, you're not able to stand up as easily as you once did. Okay, or you're having some numbness or tingling in the groin or bowel and bladder dysfunction, come see us immediately. I'd rather say it's something non-emergent and we treat you conservatively rather than miss something that should have been treated urgently and we miss the boat on it. So this is just a very thorough slide, and pretty much what it shows is, as a complex spine center, we do everything. We go from the top of the spine to the bottom, whether it's a deformity, and we have many, many different ways of attacking things. You know, whether it's a small discectomy or a disc replacement or something as invasive as a fusion, we have the capabilities to treat all that and the appropriate technologies. Now, I'm going to go a little bit off right now in the sense that we're not going to discuss surgery, but we're going to discuss conservative management. This book, written by David Hanscom, is one of my mentors. Really is a phenomenal read, and it says, do you really need spine surgery? It pretty much dissects what we need to know in this grid. The book is an easy read, both for medical professionals as well as non-medical professionals. But as long as you understand this grid, I think this is what's critical to our point. The most important thing is you want a calm nervous system, okay? Our anxiety and our pain fibers run down the same pathways. And what I mean by that is if I told an individual to stand in front of a door and glue their feet to the ground, and I'm going to open the door and it's going to hit them in the head, what's going to happen? You're going to get nervous, you're going to get anxious, and you may even develop neck pain. But if I told you, we're not going to do that, I'm just going to ask you to sit aside, go to a chair, I'm still going to open the door, but it's not going to touch you, your neck pain went away. That's from our fight or flight response, from when we weren't living in buildings and we may have been out in the wild and we heard rustling in the trees, until our bodies confirm that it's wind rustling the bush and not an animal about to hurt us. We will have our fight or flight response and all our adrenaline pumping through and put us at a higher level of anxiety. The most important thing for us is to actually treat the anxiety first. Even if there is something structural, at times with treating the anxiety and getting them through prehab, we may be able to calm down your nervous system to the point where you don't need anything surgical. So what we discussed were the structural and the non-structural. There are times you may have pain that's non-structural. And a lot of patients will say, hey, you don't believe me, the pain is in my head, you're telling me the pain in my head is in my head, there's no treatment for it. In a way, the pain is in your head because of the anxiety fibers running down into and accentuating all your pain. But we have modalities to treat that. And the modality is not necessarily a surgical modality. What we have to explain to our colleagues and our patient is this multidisciplinary approach. We want most often to have a calm nervous system at all times. By calm nervous system, you need to have your ability to sleep. You need to have other ability, an agitated nervous system. Some of the questions I ask all my patients is, what's going on in your life? Was there a loss of a loved one? Was there a loss of a job? Did you just buy a house? All those could be stresses that will aggravate your pain and may not necessarily have to push you down the surgical route. We discussed the quality of sleep and the level of chronic stress. Stress could be acute or chronic. Sometimes we don't even realize how much it affects us and how much it affects us through time. So all of these things put together will ultimately determine what your treatment plan is. And that's what we do here. It's very important to understand all the different variables before a plan is put together and we decide what treatment plan is going to be set forth. The most important one is actually the last one, which is our commitment to recovery. There are individuals that will say, hey, just give me the easy fix. Well, the easy fix isn't necessarily the surgical fix, even though it may happen. The easy fix is sometimes a little bit of hard work by not putting your life at risk through a surgical intervention, but actually pushing you and encouraging you to go through the different modalities. One of the important things that we look for is a mood questionnaire. An individual that tends throughout in anxiety, depression, and irritability, at that point have the very hyperexcited nervous system. A hyperexcited nervous system isn't going to do well through a surgical intervention. We need to first, again, I know I'm repeating myself, stay with that commitment to calm the nervous system down to see how well your body gets you on your own. So I'm going to go through a couple cases, and then I think we're going to go through the multitude of questions that have already come through, and any other questions that may come through. So this is an individual. She was 44 years old, actually worked at one of the hospitals I was attending to about 5-6 years ago, and she was in a motor vehicle accident. Severe neck pain, and she got an MRI that showed something on it, and was told she needed an immediate fusion. Well, she was like, well, let me go seek out a second opinion, and I'm going to wear a collar, and she came to seek me out. She saw me in my office. We repeated the MRI and a couple of other scans, and she was wearing her collar. But then I sat down and asked her, when is your pain the worst? And the thing she explained to me was when I'm driving or I know I'm about to have to drive. And I asked her, do you white knuckle when you're driving? And she said, yes. And for those of you that don't know what white knuckling means, it means you're grabbing the steering wheel so hard and you're adding that additional stress because you're scared of something that's about to occur. She had a pretty serious accident where her daughter was in the car with her and they were both hurt. And that is a pretty devastating injury. She did the right thing. She was evaluated at a hospital, and they did the appropriate post-traumatic scans. After she came to me, we did some cognitive behavioral therapy with one of my other colleagues, and she came to me 4 months later, and she was doing absolutely fine. She was out of her collar. She didn't need surgery. She was back to driving without any difficulty, and she was very content with this outcome, especially avoiding a surgical intervention. This next patient is a 77-year-old male, and he's been having more and more difficulty walking. When asked, he has what we call the shopping cart sign, meaning whenever he goes to a grocery store, he leans over the shopping cart to kind of help him move along. What this gentleman has is called stenosis, or meaning pressure on his nerves in his lower back or in the lumbar spine. The reason he leans over the shopping cart in particular is he's kind of doing a surgical procedure on himself naturally. By bending over, he's opening up the pressure on his nerves. This individual went through therapy and through all the prehab. He did end up going through a surgical intervention, and ultimately, he did wonderful. Another case example is an individual with a pretty bad-looking spine, and you don't necessarily need to be in the medical field to recognize that that's not the best-looking spine. He again went to several other individuals and came to me as an opinion. And we did a procedure on him, which was a little bit more minimally invasive, where we went in through his side to put in a cage. And what we do is we make a small incision on his side. It's called a lateral lumbar inner body, which means between the vertebrae fusion. We put in a cage, and we corrected part of his deformity. And he was in the hospital for less than 2 days, and he's doing great. So what I've kind of shown here is from the non-operative to a little bit more minimally invasive to something that requires, even though it's a minimally invasive procedure, a little more of an extensive surgical portion. So in conclusion, what we're doing here at the Hurley Spine Center is we really are developing a patient-centric, multidisciplinary spine team, where you are not going to see just one individual, you'll see all of us. And that doesn't mean that all your individuals need to be here at the Spine Center. We will we'll be more than happy to converse with your physicians at other facility just to make sure we're all on the same page in order to really give you optimized, individualized care. More importantly is to be a minimalist. And lastly, what I always was taught by my mentors is take care of today's problems today, tomorrow's problems tomorrow, because there's a very good chance they may not become problems, and we may have resolved it in a more simple fashion.
All right, good stuff. If you have a question for Dr. Moisi, text it now to 248-935-2562, or submit your questions on Facebook or YouTube. Now, we have a lot of questions in. I'm going to try, some of them are very similar, so I'm going to try and group them up, get as many people answers as we can. The first group of questions, and 3 or 4 people asked about pinched nerves. Some people say they already had surgery. Some people are wondering if there are exercises to do. Is there something you can do without going the surgical route? Could you talk about pinched nerves a little?
Absolutely. So pinched nerves could be from various different reasons. It could be from something as a herniated disc. It could be from what we call arthritis. or bone chips, as some people call it, or bone spurs. The go-to thing with this is trying to avoid a surgical intervention, whether you've had one before or you haven't had one. There are a multitude of exercises, and that's why I like evaluating my patients even if they don't need surgery. In fact, I operate on less than 10% of my clinic, and over 80% of patients get better on their own with all these different conservative therapy modalities.
This has never happened before when we've done one of these, but somebody just delivered us an emergency message for you from about a patient, so I'm going to hand that over and see if there's something Doug can relay to them, or if you can wait.
Yes.
Or
Thank you.
Okay. All right, let's get back to the questions.
My apologies. This is real time at a level 1 trauma center.
Okay. Laser surgery for neck pain?
So laser surgery is kind of, it started a while back with the Laser Institute in a different area of the country. The issue with that is it was really an acronym. Surgery, when we do it, is still open surgery, whether it's minimally invasive or not minimally invasive, okay, depending on what your needs are. We typically rarely use lasers in the spine. Sometimes they are for certain ailments. But there are more and more minimally invasive techniques that we all aspire to do, and as little as possible, as we mentioned, to be a minimalist.
If you're on Medicaid and Medicare, will that limit your choices?
It should not. You know, working at a level 1 trauma center, we see every single patient no matter what. When it comes to insurances, some of the other specialists may limit it, but we work with you to find the appropriate specialist to help you with your needs at all times.
Are inversion tables helpful for herniated discs and stenosis?
So they definitely are part of the armamentarium of what we use with some of our patients. I still think that you should probably be evaluated first by a professional prior to jumping in to diagnoses. One thing I may add is one of the scary things of a patient to come see me, they're like, okay, if I'm seeing a surgeon, that means I'm 100% getting surgery. My philosophy is I want to meet you early to develop a rapport with you. If you ever need surgery, I think it's a nicer and more professional to have a rapport with you, whether it's 6 weeks, 6 years, or 20 years, rather than saying, hey, I'm Mark, we're going to have surgery next week.
Jody says, after 3 failed steroid injections in C-spine, what's next? And we've gotten a lot of questions about injections and people who are still feeling pain or their pain comes back.
So that's a great question. It's not the easiest one to answer due to the fact that we need to look at the scans and see why did you fail the injections? Did the injections help and they're no longer helping? So this would be an appropriate question to pose to myself or any other spine surgeon in an office setting after we've evaluated your films.
Can anything be done for degenerative issues like arthritis?
So a lot of it is getting good, is our whole prehab concept. You know, I say in jest that we live on Earth, and the only way to avoid getting worse on arthritis is to go to a non-gravitational area. So unless we move to the moon, we're kind of stuck with that. So getting your core as strong as possible, working out, doing the appropriate stretches will hopefully at least help with the pain, even if it doesn't necessarily help with the progression of the arthritis. What ultimately we want to do is help with the progression of arthritis, or at least try to slow it down so you're living your best days ever.
Is fusion better than artificial disc replacement?
That's a phenomenal question. 2 things. One is it really has to be individualized to the person and depending on what their ailments. Number two, I think if you say that in a room full of spine surgeons, it's going to be split down the middle depending on their beliefs. There's great literature supporting both, and depending on the individual and their ailments, I think it needs to be individualized rather than just throwing out a generic question.
I've gotten a couple of questions from people who, have a slew of back problems, but they have other health issues. One has heart issues and a pacemaker. One's worried about their age, that they're elderly, and they want to know if those kind of things limit your choices.
In a way it does in terms of surgery if they're not healthy enough. But again, going to kind of what we're trying to drill in today is the fact that we're trying to avoid a surgical intervention if we can. If it doesn't matter what your other ailments are, we will work with you to try to find the best path and the best treatment plan that's individualized to each person. And that's one of the things that we pride ourselves on, is that we do individualize it rather than just throwing a generic catchphrase that will try to, instead of figuring out what will benefit each individual, that we will capture what their best outcomes are and what their life goals are. If someone comes into us and they want to play football for the next 30 years, that might be one treatment plan. If someone wants just to be able to walk and work around their yard and just be able to cook dinner, that's another treatment plan. So that's what I mean, that we need to individualize each person's care.
Do you suggest a chiropractor, and if so, how often?
I think, I work very closely with my chiropractor colleagues. I think you need to be evaluated by both both a spine surgeon as well as a chiropractor. I don't make the chiropractic plans. I just determine if it's safe. There are certain ailments where it would be less recommended. All others are fine, and I would suggest that you seek out your chiropractic colleague.
Can you define mechanical failure in regards to rehabilitations?
That's actually a tough question. I'm not sure what they mean by that, so I apologize.
Okay. If that came in through a text, so
maybe if they could clarify if they mean, mechanical failure could mean a lot of things. Was it related to a previous fusion? Was it a fracture? Are there muscles incapable of holding up their body, and they need more core strengthening? So it's a little bit difficult to answer that directly.
That was Susan's question, so if she's watching, she might want to follow up a little bit on that. Do you have suggestions for golfers?
Yeah, core strengthening. Golfing. So when it comes to spine care, the one thing that, especially when you have an injured back, we say no bending, lifting, and twisting, or BLT. Well, golfing incorporates all three in one move. So what do we say is most important for golfers is actually having a good core strength. Because if you could move your core in a good, with good mobility and agility, and it's strong enough to maintain all your biomechanical motions, you should be fine. Weaker cores need to be careful, especially if you've had previous back injuries.
I had no idea that so much leg pain was associated with your spine, but there's a lot of questions about people who had that. They're saying that they, had surgery on their C4 and C7. The neck pain got better, but leg pain's still there. A lot of people are asking, what do they do when
So let's kind of go back and kind of redraw pain. So the pain, it's called radiculopathy. It could be going down your arms or going down your legs. If you've had a neck surgery, that was more specialized for your arm pain. or if you had leg weakness. If you're having leg pain after a neck surgery, you probably need to be evaluated for your lower back, and we may have to individualize your treatment as to strengthening your lower back, or at least determining what's going on in your lower back. And vice versa. If you've had back surgery on your lower back and you're having arm or neck pain, you'll probably need to have your neck or your arm or your cervical spine evaluated at that point.
This kind of piggybacks on that, but are back issues related to neuropathy in your feet?
Neuropathy could be related to back issues. There's a multitude, and I could probably speak for the next 3 hours about neuropathy. Typically, there's a component from diabetes. There could be from the back. So it's very hard to predict without seeing an individual in person and evaluating their appropriate images.
Can you explain electrolysis and how that might help?
So that depends where it's being used. A lot of it is just to help with the muscle pain, and I think it's a very important component of our conservative management treatment plan.
How long have you been doing surgeries?
So I graduated med school in '05, and between training and this, so I guess 17 years. I didn't have to ask Alexa for that mathematical.
Are quarterly depot-medrol injections harmful for stenosis?
So again, one of the things we need to determine is, are we doing them quarterly with help? Are we doing them quarterly without help? If they're helping you, I think they're a reasonable treatment plan, and you need to discuss that with the pain specialist that's giving you those injections. And it really depends on your other medical problems and if your body will take it.
A couple of questions about scoliosis. Mm-hmm. Are there certain procedures that are better, and is it something that's going to get worse?
So scoliosis, and actually Scoliosis Month is starting in about a week because June is Scoliosis Month. So with scoliosis, it really depends. Scoliosis could be the type that you have as a kid that could potentially get worse, and that's a different box than scoliosis as an adult. As an adult, there are many different treatments. A lot of times it's not surgical. And if it is surgical, you don't necessarily have to correct it all. With scoliosis, the different treatments do include conservative management with different lengthening procedures, stretching procedures. I saw an individual recently with a very, very bad curve, and it's been stable for the past decade. So at this point, if it's stable, the individual is only having minimal problems, there's really no reason to pursue it any further at this time.
Is there a minimally invasive surgery to relieve sacroiliitis pain?
So, yeah, so those typically, before we even jump into that, I would say a good portion of our patients get better with conservative management and then possibly 1 or 2 injections. But there are minimally invasive procedures, including fusions for that, if we get to that point in the treatment plan.
Is yoga okay for sciatic nerve pain?
100%. Yoga, and if you're really, really, really motivated, Pilates, because with that, you really have to prove your core strengthening abilities.
Cassie wants to know, is there a determining factor to get nerve stimulator implanted?
That, again, is a long process. We have to discuss all the pros and cons and the risk and benefits of the procedures. Typically what we do for those is you first end up with a trial procedure to see if it even works, should you want to go down that route. After the trial procedure, if it does work, then we could discuss a permanent implantation.
I do have to feel for so many people because there's so many people here who are have tried a lot of things. Scott said he's done physical therapy, medications, it still hurts. Geraldine says she has bulging disc bone spurs and has had physical therapy and injections and nothing seems to work.
You know, bulging disc is kind of a catch-all phrase that is a little difficult because if you look at MRIs, and now we live in the era of everyone gets a scan. If everyone gets a scan, then we're going to find things that may not necessarily need anything. So there have been studies that show that 30% of 30-year-olds, 40% of 40-year-olds, 50% of 50-year-olds, and so on and so forth, will have some sort of a bulging disc on an MRI if they're scanned. That doesn't mean it's causing anything or causing any ailments. It's just there on a scan. And what I try to tell every patient is, I'm not here to fix your scan. I'm here to help you with your symptoms so you can live your best life possible. If you want me to fix your scan, I'm not the right person. Sometimes we do need to do it, but it's in a minimalist fashion at all points. Going back to the yoga and Pilates question, another thing that I recommend to everyone are learning how to do planks on a daily basis in a correct fashion, because that is an easy, simple way to build core strength very simply in your own house.
What are the treatments for osteoporosis?
So usually for osteoporosis, I would incorporate my endocrine as well as my internal medicine colleagues. First you would need a DEXA scan, which means it looks at your bone quality. And then after that, you may require some medications, whether for the short term or the long term, depending on the extent. The important thing with osteoporosis is trying to avoid surgery when you're at your worst, because that will just lead to a domino effect.
When should sleepy arm be investigated?
If it doesn't go away, typically. It depends, you know, because all our arms can fall asleep. It may require something simple like an EMG just to make sure. It may not be coming from your spine. It may be coming from one of the nerves, or it may just be unrelated. So anytime it's continuous, I think you need to be evaluated.
Now this person says their neck is straight, but their skull sits wrong. Is there anything they can do?
At that point, we need to see you in our clinic to see what you mean by that. It could be related to a little bit of stress on one side of the muscles and just simple stretching or relief from the muscles. What's important to realize is our neck muscles are so much smaller in comparison to the rest of our back muscles. And if you think about it, our heads are pretty heavy. So they have a huge responsibility, and depending what you do in your life, if you know, I'm guilty as charged, I'm a surgeon, I look down a lot during my day. So I need to do my neck exercises in order to ensure that I don't have neck pain at the end of the day.
Do you have a recommendation for neuropathy caused by chemotherapy?
For those, typically I would suggest talking to one of your physicians. Usually those are treated with medications.
And I think this might be the last one. Spinal stenosis in the lumbar area. What are non-invasive, invasive options? You may have talked about this already.
Invasive or you said non-invasive and invasive.
Non-invasive.
So non-invasive would include your physical therapy, core strengthening. And what I try to tell every patient is, I am not here to convince you you need surgery. I'm actually here to convince you you don't, so we could see if we could get you better without it. In turn, if you've hit your tipping point, you're going to convince me that there's nothing left to do other than a surgical intervention. And then we may have that discussion depending if there's appropriate imaging that matches your symptoms.
Okay, I think I've hit on everyone. There's, several people had very similar questions with their specific issues, so I hope that they got the answers that they want. Also, a couple people were asking about pricing things, so I just want to say that if you do want to make an appointment or you do have a question about that, it's best probably to call the office, and that number is 810-262-7030. Or you can just head over to hurleymc.com. Our next virtual Healthy Living event will help you with hernias. Look for that on June 30th. Thank you to Mid-Michigan Now for being such good broadcast partners, and have a great pain-free day, everyone.
Thank you for having me.